Good evening, everyone. We have with us Dr. Hemanth, which is a second year DM president. Dr. Sushma is going to just join us in a while. So can I request Dr. Hemanth to just please start with the presentation of a journal club?
Thank you, ma'am. Good evening, everyone. Today is my journal club, and we are presenting from Lady Hardinge Medical College. The moderator today is Dr. Sushma Nangia, who's the Director, Professor and Head, Department of Neonatology, and our Assistant Professor, Dr. Gunjana Kumar. The original article was a trial of erythropoietin for HIE in newborns. It was presented in the New England Journal of Medicine. It was published on 14th of July and this year. The trial was registered as the HEAL trial, which is high dose erythropoietin in asphyxia and encephalopathy. The impact factor of the journal is 35.41. Coming to the background, neonatal HIE is an important cause of death as well as long-term disability in survivors. It causes around 2 to 3 deaths per thousand births. Therapeutic hypothermia has been proven to be the only neuroprotective therapy that improves neurodevelopmental outcome in humans in studies till now. Recombinant human erythropoietin has been proposed as a potential adjuvant therapy for neonatal HIE. The evidence supporting the use of erythropoietin for neonatal neuroprotection is limited by the small size and short follow period of previous studies. The HEAL trial, which is the high dose erythropoietin for asphyxia and encephalopathy, was conducted for this purpose to study the safety and efficacy of erythropoietin along with in conjunction with the therapeutic hypothermia for neuroprotection. Coming to the methods, it was a multi-center. It was performed in 17 sites with including 23 hospitals in the USA. It was double-blind, randomized, placebo-controlled trial. The randomization took place from 2017 to 2019. The following were the inclusion criteria. Infants were eligible if they met the following 4 criteria, that is 36 weeks or more gestation, 1 or more signs of perinatal depression, which included Apgar score less than 5 at 10 minutes, cardiorespiratory resuscitation received beyond 10 minutes of age, and a pH of less than 7, or base deficit of more than 15 in the umbilical cord, or obtained within 60 minutes of birth. Others were moderate or severe encephalopathy according to Sarnat criteria at 1 to 6 hours of life, and receipt of active or passive therapeutic hypothermia that was started within 6 hours after birth and continued for the first 72 hours. The following were the exclusion criteria, which were birth weight less than 1.8 kg, head circumference less than 30 centimeter, any genetic or congenital condition affecting the neurodevelopmental outcome, hematocrit more than 65%, parents considering redirection to palliative care, encephalopathy attributed to a postnatal event, the surviving twin undergoing hypothermia, anticipation that the child would be unavailable for evaluation at the randomization sequences were produced by Central Data Coordinating Center. The randomization was stratified according to trial site and severity of encephalopathy. Written informed consent was taken before randomization. The dose of erythropoietin used was 1000 units per kg, or compared to the placebo sequel volume of saline, which was given intravenously before 26 hours of age at 2, 3, 4, and 7 days of life. In the study, all the trial staff except the pharmacist at the trial site and the statistician at the data coordinating center were unaware of the trial group assignments. Coming to the outcomes, the primary outcome was either death or neurodevelopmental impairment. NDI was defined as any of the following: either cerebral palsy determined by means of validated standardized neurological examination, a gross motor functional scale level more than or equal to 1, and Bailey scale score, cognitive score less than 90. Originally, the final outcome assessment was supposed to be between 22 to 26 months, but due to COVID-19, the period was extended up to 36 months of age. This was instituted on 8th May 2020 and approved by the FDA. Secondary outcomes were death, cerebral palsy, gross motor functional level scale, the Bailey scale score of cognitive and language score, and it was a 4-level ordinal outcome consisting of either death, moderate or severe neurodevelopmental impairment, mild impairment, or no impairment. The severity of brain injury was also based on an MRI validated scoring system, which ranged from 0 to 144. Higher the score was more severe injury. Behavioral abnormalities were indicated by an externalizing score on the child behavioral checklist, which was up to 65 or more. Serious adverse events also were taken into the outcome, which were either death, hypertension warranting medical treatment, hematocrit more than 65%, thrombosis unrelated to central catheters warranting anticoagulation or involving a major vessel, DIC with clinical bleeding and warranting transfusion of blood products, pulmonary hypertension warranting inhaled nitric oxide or ECMO, intracranial hemorrhage, and cardiopulmonary arrest and other unexpected life-threatening events. Using phase 2 trial data, cumulative incidence of death or neurodevelopmental impairment was estimated to be 49% among children who received placebo. On the basis of animal studies in phase 1 and phase 2, estimated cumulative incidence is 31 to 35% among those who received erythropoietin. Assuming a 90% follow-up rate at 22 to 26 months, estimated sample size was 500 with 90% power to detect a relative risk difference of 33%. It used a modified intention to treat approach where at least even if one dose of erythropoietin or one saline bolus placebo was given, were all included. Primary analysis evaluated the equality of the incidence of death or neurodevelopmental impairment across the two groups. Secondary outcomes were evaluated with the use of adjusted linear or logistic regression models. The two-sided significance level of 0.05 was used for the pre-specified efficacy hypothesis test. After 125, 250, and 375 infants had been enrolled, the data and safety monitoring board compared the mortality and rates of serious adverse events according to the trial group using appropriate small sample methods such as the Fisher's exact test. Coming to regression analysis, it is a set of statistical methods used for the estimation of relationships between a dependent variable and one or more independent variables. There are multiple types of regression analysis, which may be linear or logistic. Under linear, we have simple linear and multiple linear. And logistic, we have one binary and it has polynomial logistic, multinomial. In simple linear, we compare a dependent variable and its nature with an independent variable, and it is only a single continuous normally distributed variable. In multiple, we compare one dependent variable with two or more continuous or categorical independent variables. In logistic, we use one binary, that is a yes or no or 0, 1 value, and it is compared to an independent variable, which may be multiple. The relationship between the variables need not be linear. Coming to the trial enrollment and follow-up, 1,300 infants were born at 36 weeks, or more than 36 weeks of gestation, who received and maintained hypothermia, were assessed for eligibility. Out of them, 799 did not undergo randomization, in which 477 were excluded because 237 had mild HIE, 58 did not have perinatal depression, 57 had birth or genetic exclusion, 42 had redirection of care by the parents, 45 were unlikely to be followed, 38 had other exclusion, 322 were eligible but consent was not given. The remaining 501 underwent randomization, but one of them did not receive a trial intervention owing to not meeting the inclusion criteria. 500 received a trial intervention, which is a modified intention to treat population. 387 of them had moderate HIE and 113 had severe HIE. In which 257 were assigned to, out of the 387, the 500, 257 were assigned to and received erythropoietin, while 198 had moderate HIE in the erythropoietin group and 59 had severe HIE. In the erythropoietin group, 17 were excluded as 11 were lost to follow, 4 had incomplete examination, and 2 did not have examination completed within the trial window. So at last, we had 240 patients, 93.4% included in the analysis at 24 to 36 months of age, in which 37 died before examination and 203 underwent examination. In the placebo group, we had 243, which were assigned to and received placebo. 189 had moderate HIE, 54 had severe HIE. 21 were excluded as 8 were lost to follow-up, 1 was withdrawn, 10 of them had incomplete examination, 2 did not have examination completed within the trial window. totally we had 222, that is 91.4%, which were included in the analysis at 24 to 36 months of age, out of which 28 died before examination and 194 underwent examination. Coming to the results, this is the demographics between the erythropoietin and placebo group, and there was not much difference between the two groups. This is the primary outcome between the erythropoietin and placebo group plotted on a forest plot, which showed not much difference between the death or neurodevelopmental impairment between the two groups. In the secondary outcomes, there were not much difference except in the score for externalizing problems on childhood behavior checklist, where there were 15 out of 207 patients in the erythropoietin group, that is 7.2%, compared to 3 out of 201 patients in the placebo group, that is 1.5%. Coming to the serious events, the adverse events, in the erythropoietin group, the total number of serious adverse events were comparatively more compared to the placebo group, that is 221 compared to 163. And the erythropoietin group had at least one serious adverse event. Multiple high doses of erythropoietin did not significantly affect the incidence of death or neurodevelopmental impairment at 2 to 3 years of age. The infants who received erythropoietin were more likely to have at least one serious adverse event and had a greater number of serious adverse events than those who received placebo. The previous results contrast with those of previous studies involving neonates receiving multiple high doses of erythropoietin. The possible explanation for this were, one of them was both hypothermia and erythropoietin may initiate similar neuroprotective pathways, and which because of the use of hypothermia in the trial may have reduced any potential benefit for the additional benefit from erythropoietin. The toxic effects of erythropoietin administration early in the injury cascade when combined with therapeutic hypothermia. It may be due to suboptimal dosage or timing of administration. The differences in engineering mechanisms between the preclinical models which were tested in animals and now in human hypoxic ischemic encephalopathy. No single type of serious adverse event was substantially more common in the erythropoietin group. The higher incidence of behavior abnormality was observed at 2 years of age in the erythropoietin group. There was no appreciable difference between in the group differences in findings on MRI of the brain or functional outcomes. In preclinical models, erythropoietin was seen to improve the regeneration of brain tissue after the acute phase of HI injury by enhancing neurogenesis, oligodendrogenesis, and angiogenesis, and also by stimulating growth factors, including brain-derived neurotrophic factors. The delayed cytoprotective effects may explain why erythropoietin appears to be neuroprotective in rodents, even when treatment is not started until 3 to 7 days after focal ischemic stroke. Coming to the limitations, the study was unable to address the usefulness of erythropoietin in the absence of therapeutic hypothermia, which is usually not seen in, which is not much used in low and middle income countries. Some children were evaluated in a delayed fashion owing to the COVID-19 pandemic, and due to which the study period had to be extended. The patient sample is representative of only infants with HI in the United States, and hence it is not generalizable to other countries. Coming to the consort adherence, identification as a randomized trial in the title, no. Structured summary of trial design, yes. The introduction, there was a scientific background and explanation of rationale provided. Specific objectives were also provided and hypothesis, which show the primary outcomes and secondary outcomes being evaluated. The description of the trial design was mentioned. Important changes to the methods after trial commencement were along with the reason was also mentioned, where due to COVID it was prolonged. Eligibility criteria for participants, the inclusion and exclusion criteria was mentioned in the article. Settings and locations were also mentioned, where it occurred in 17 sites in 23 hospitals. The intervention was also explained in the article between saline placebo and erythropoietin. Outcomes, the primary and secondary outcome measured and how and when they were assessed were also mentioned by the article. Any changes to the trial outcomes after the trial commenced was also mentioned in the article. How the sample size was determined was mentioned. When applicable, explanation of any interim analysis and stopping guidelines. Randomization, the type of randomization, details of any restrictions such as blocking and block size. The block size was not mentioned. Allocation concealment, mechanism used to implement the random allocation sequence such as sequentially numbered containers was mentioned in the article. The who generated the random allocation sequence was also mentioned, as it was done by a data coordinating center, central data coordinating center. Blinding was done. It was a double blind study. Statistical methods used to compare groups for primary and secondary outcomes were also mentioned. The methods for the additional analysis, such as subgroup analysis and adjusted analysis, were also mentioned. In the results part, for each group, the number of participants who were randomly assigned received intended treatment and were analyzed for the primary outcome. Yes. For each group, losses and exclusions after randomization together with reasons. Yes. Recruitment dates defining the period of recruitment was also mentioned. It was between 2017 and 2019, and follow-up was up till 26 months originally, which was extended up till 36 months due to COVID-19. The trial was continued until completion, and in between it was at 125, 250 and 375 patients. It was studied also. A table showing the baseline demographic data and clinical characteristics for each group was provided in the article. For each group, the number of participants included in and whether the binary outcomes. For binary outcomes, the presentation of both absolute and relative effect size is recommended, which is not applicable in this. Discussions wise, the trial limitations were mentioned. Generalizability, no, as the generalizable as this included only the 7. Say. Interpretation was consistent with the result, balancing benefits and harms and other relevant evidence. The registration number and name of the trial registry was also mentioned in the article. Full trial protocol can be accessed the any sources of funding and other support was also mentioned in the article. Coming to the critical appraisal skills program checklist, yes, the population involved, nature of intervention, comparative and outcomes were clearly defined. Was the assignment of patients to treatments randomized? Yes, it was a double-blind randomized placebo-controlled trial with allocation concealment. Were all of the patients entered the trial properly accounted for it at its conclusion? Yes, modified intention to treat analysis was done. Were the participants, staff, and study personnel blind to a participant's study group? The trial staff were unaware of the trial group assignments except the pharmacist at the trial site and the statistician at the data coordinating center. Were the groups similar at the start of the trial? Yes, the baseline characters were comparable for both groups. The demographics were provided in the article. Aside from the experimental intervention, were the groups treated equally? Yes. Can the results be applied to the local population? No, as it was generalized only to infants with HIE in the USA. Were all clinically important outcomes considered? Yes, it included mental impairment, other secondary outcomes, as well as serious adverse events and death. Were the effects of intervention reported comprehensively? Yes. Was the precision of the estimate of the intervention or treatment effect reported? Yes, as the confidence intervals were mentioned. Would the experimental intervention provide greater value to the people in your care? This we cannot tell because this trial included erythropoietin only along with therapeutic hypothermia, not in the absence of therapeutic hypothermia. Thank you.
So, thank you, Hemanth. Hello.
Yes, yes.
Yeah, thank you. Thank you, Hemanth, for that very lucid presentation and bringing out the details as well as assessing it on the checklist. So I will open this for questions from the floor. I think there is a question in the chat. Why was modified intention to treat used in this trial? Yes, Hemanth.
Ma'am, it's not exactly mentioned actually, but according to them, they use the modified intention to only those who received at least one saline bolus or at least one erythropoietin dose, they were included in this.
Just for, can I just speak, ma'am? Gunjana, this side, ma'am.
Yeah, sure. Please go ahead.
So there is a difference between the two things. One is intention to treat analysis and modified intention to treat analysis. In intention to treat analysis, all the participants which are being randomized must be included in the final analysis. And they are supposed to be analyzed according to the treatment group which they are assigned to, irrespective of the fact whether they have received the treatment, whether there is any withdrawal, or whether there is any loss to follow up. So there is no standard definition for modified intention to treat analysis, and every article or every people who are conducting a randomized control trial, they take modified intention to treat analysis on their own trial basis. So in this trial, they have included modified intention to treat analysis, as when the Hemanth has shown the complete trial enrollment and follow-up flow diagram, they have excluded one baby which was accidentally included in the intervention arm, although that baby doesn't receive any erythropoietin. So when they did a final analysis, they have did an analysis for 500 babies, not for 501 babies. So they have excluded that one baby which was accidentally enrolled in the erythropoietin arm, but it did not receive any dose of erythropoietin, so that baby was excluded. So this was the only reason which was mentioned. Otherwise, they have not mentioned any other reason for that.
I think there is one more question in the chat box. And that relates to, can primary and secondary outcomes be same, like death and neurodevelopmental outcome?
In this primary outcome, they said only death or neurodevelopmental outcome impairment, but in secondary outcomes, they even took it in an orderly manner, as in whether it is mild, moderate, severe, or is in neurodevelopmental impairment or death. And there were other secondary outcomes also, like picture on MRI imaging, severity, and whether there was presence of cerebral palsy or not, and Bailey scale scores at cognitive score and the language score also.
Just to add on.
So probably this must be a composite score for the primary outcome, and for the secondary outcomes, individual aspects may have been taken. Gunjana, you can clarify it further.
What you told was, this is what I was about to tell, that in the primary outcome, they have included death or neurodevelopmental impairment. But while doing a secondary analysis, in the secondary outcome, they have taken death separately. And in fact, the neurodevelopmental outcome, they have divided on the further basis. This is what, ma'am, just what you have told, the same thing, ma'am.
So basically, let me see who's asked that question. So Nahim, this is absolutely acceptable. And when you expect that in a trial, death alone is going to be an outcome which will be quite scarce. It will not occur that frequently, or for that matter, even neurodevelopmental outcome. So you are quite, it is quite acceptable that you take a composite outcome. And in the secondary outcomes, I mean, as a primary, you could take a composite outcome. And in the secondary, you show them individually, which gives us the leeway for using that for further hypothesis making and doing a trial subsequently, where maybe one can be taken as a single outcome if you have enough results in this kind of a trial. So this is absolutely fine.
Okay, thank you, ma'am.
Okay, Hemanth, there is another question which says that any difference with respect to LMICs, and or is there any ongoing research in the LMICs?
The problem with this article